This chapter covers oxygenation, and if you can tie this chapter to your guidance, you see it tied to both the concept of perfusion and the concept of gas exchange. So thus you will appreciate why you need to go back and review the function of the cardiopulmonary system in general, the structure and the function. So come bring forward the knowledge of the physiological processes of ventilation, perfusion, gas exchange, cardiac output, myocardial blood flow, systemic circulation, pulmonary circulation, the process of oxygenation. How does the cardiac output play in that process of oxygenation? What does the preload, afterload, contractility, and heart rate has to do with oxygenation? What are some of the potential clinical consequences of hyper or hypoventilation and or of hypoxemia? What are some of the clinical manifestations? What are some of the risk factors to alterations, and plus how does the alteration affect the functional capacities? These and then some more we're going to cover in this chapter. I advise you in the Giddens PowerPoints to go back and refresh your knowledge base around the respiratory physiology. I have uploaded the PowerPoints to the crash course. He's a so funny guy, and I uploaded both his two chapters about respiratory and the cardiology part, and you'll definitely find him funnier and more conducive for learning. This slide is gonna come after you have watched those refreshers on the anatomy physiology of the cardiopulmonary system. So when we come here, we're gonna talk about how the conducting airways and bring upon the ventilation and how gas move into the in and out of the lungs really, but into those conducting airways, and then come here to the alveoli to have the real uh, um, respiratory gas exchange. So you know that at the level of alveolar ducts that they're engulfed with this uh, pulmonary arterioles and venules and those capillaries, and so the sacs, the alveolar ducts or the sacs really have high oxygen content, and those vessels at adjacent to them have lower level of oxygen. The also alveolar sacs have high level of CO2, and those vessels have a high level of CO2. So what happens is an exchange, but it's not exchange oxygen for CO2. It's really exchange of oxygen from a higher concentration to a lower concentration and exchange of CO2 the same way. And that's how we will have ventilation, perfusion matching, and we'll end up with good oxygenation. So you can see that in figure 41.1 in your textbook, and that's how adequate oxygenation is achieved. The other thing is about the cardiovascular physiology is also, again, you're watching the YouTube video and you're coming here after, and if at all the pumping is reduced, and you know that the oxygen is carried on those red blood cells. It needs the carrier, which is the vasculature, to get it around. And so if there is any abnormalities in the anatomy of the heart, for example, if there is an opening in the septum between the artery, the atriums, or between the septums in the ventricles, so then the poor oxygenated blood mixes up with the oxygenated blood, so you have a problem there. The other problem, if the pumping is not adequate, you don't have adequate systemic circulation, so that is also going to affect. Also, if the conduction system is disrupted, so if you have irregular heart rate, dysrhythmias will also result into poor oxygenation. So that's how they're tied together. They're tied together in more connections than I want to describe in here, but that's a main point. So after we have completed our readings and watch, if we want to watch the videos about how the normal physiological and structure and function of the lungs and the heart, the cardiopulmonary system, we come and look at what are some of the factors that will affect that cardiopulmonary functioning. And we find four different factors. Factors that are related to physiological factors, developmental factors, lifestyle factors, and environmental factors. In the physiological factors, we'll see that any condition that affects the functioning of the cardiopulmonary to meet the oxygen demand is going to be impacting it uh, uh, physiologically. So decreased oxygen carrying capacity in the sense that we don't have those bodies to carry the oxygen. Hemoglobin is usually those bodies. When do we have less hemoglobin? In cases of anemia. So you'll get to see that. And another case where we have less oxygen on the hemoglobin is when carbon monoxide, which is sometimes inhaled in fires and whatnot, it competes with oxygen on the hemoglobin carrying places. So that's a one oxygen carrying capacity decrease. Hypovolemia can occur either because there is blood loss or because there is, a shock and you have that severe dehydration or extracellular fluid loss from burn. So that these are causes for physiologic factors that affect oxygenation. Then you have the really just the poor oxygen concentration. For example, if you're on high altitude, that's a normal thing that happens, but you have decreased environmental oxygen nonetheless. Or if the person is merely not breathing enough when they're hypoventilation, such as in the case of opiate overdose. But then you have places where you just simply have a blockage in either in the upper or lower airway. You have obstruction, and then that limits the delivery of inspired oxygen to the alveoli. And the other main reason is increased metabolic rate. You see increased metabolic rate in normal physiologic functions, such as in the pregnancy, when we have wound healing, when we are exercising. Also, we see that increase in fevers, but also we may see it increase in situations such as in burn, where there's increased metabolic demand on the body. The next set of conditions that affect oxygenation are due to chest wall movement. And here again we see pregnancy because the fetus is going to grow and press against the uh, push those abdominal contacts against the diaphragm, so we'll have less inspiratory capacity, and so you'll see exertion and increased fatigue because of that. So any condition really that reduces that chest wall movement is going to lead to decreased ventilation. So anything that pushes against the diaphragm, trauma. So obesity also is another, especially morbid obesity, is correlated with reduced lung volumes, and now you have more surface for the lungs to cover, and especially if they're laying in a recumbent or supine position. Um, then you have the musculoskeletal abnormalities, and that's when you have impairment either from abnormal structure or muscular disease, neuromuscular disease, central nervous system diseases. You'll read about many of those as you go along. But the structure of the vertebral column also plays a role, like kyphosis, lordosis, scoliosis. They all affect the chest wall movement. Trauma Flail chest is when you have a penetrating wound and then the chest becomes flail, moving without stability. So you'll have that chest wall instability because of multiple rib fractures. That is just merely the chest wall movement is disrupted. When you have um, we talked about musculoskeletal disease and neuromuscular disease in the fact that the ventilation is impaired and you will have resulting atelectasis, hypercapnia, hypoxemia. Myasthenia gravis, Guillain-Barré syndrome are examples. Central nervous system, you see when you have spinal cord injuries, anything above the level of C4 is gonna have effect on the phrenic nerve and causes paralysis. Also, chronic lung conditions is gonna cause decreased oxygenation. Many of those conditions, such as emphysema, will cause chest wall diameter changes. So you'll have that barrel chest. Because of excess use of the accessory muscles and the air trapping, or and cystic fibrosis. Also, you'll have those symptoms. So you'll have dyspnea, tachypnea, hypoxemia, and hypercapnia in those conditions. The next is alteration in respiratory function, and that's when simply the illness affecting that respiratory system causes either hypoventilation, hyperventilation, or hypoxia. And really, what we aim in any of the gas exchange is for the carbon, for the PaCO2, the partial arterial carbon dioxide percentage to be between 35 and 45, and for the PaO2 to be between 80 and 100. So with the hypoventilation, what happens there is alveolar ventilation is not able to meet the demand of the body and eliminate sufficient carbon dioxide. And it happens for many reasons, either because of atelectasis, simply those alveoli are collapsed, or because of obesity, where there is more demand than the supply. In hyperventilation, for example, when a person is anxious, severe anxiety, in severe infections, and acid-base imbalances, the person is going to be in a state of ventilation where the lungs try to remove carbon dioxide faster than what is produced by the cellular metabolism. So you will have that mismatch again. Hypoxia is the inadequate tissue oxygenation at the cellular level. Remember, we discussed this in perfusion. So here what we have is deficiency in oxygen delivery or oxygen use at the cellular level. And this is really a fatal condition if it's untreated, and can cause problems at the cardiac and the ventilatory level. The you're gonna see major signs, clinical manifestation of hypoxia are apprehension, restlessness, inability to concentrate, altered level of consciousness. It's all gonna affect your level of mental status. So be on the looks for those signs for your patient. You will know that these are signs of the hypoxia. When we talk about the cardiac, we say it is front and center when we talk about oxygenation. We talked about a little bit when we have disturbances in conduction, uh, we're gonna have irregular rhythm, and that irregular rhythm is gonna cause the heart to not be able to pump the adequate blood, or simply not pump at all, such as in the case of ventricular tachycardia and ventricular fibrillation, where you don't have any pumping at all. So that is one reason. Another reason is the failure of the myocardium itself to pump enough volume to reach the organs, to reach the systemic organs circulation, to reach the pulmonary circulations. That happens mostly in any kind of heart failure, whether left-sided heart failure or right-sided heart failure. Then you have the impaired of the valves that are in between the two chambers of the heart, between the left atrium and right atrium. There is a valve, and between the right atrium and the right atrium and right ventricle, there is a valve. So if any of those are either obstructed or flail, they can cause obstruction or regurgitation, so the volume will go back. And you have, different valves also. You have the aortic and pulmonic valves. These are called the semilunar valves, versus the uh, tricuspid and bicuspid valves. Um and in mitral regurgitation, what happened is that the mitral leaflets, for example, don't close completely. So that's an example of the regurgitation. And if you were looking for murmur or that whooshing sound, that's what you heard when the patient had impaired valvular function. Myocardial ischemia is really like similar to ischemia of any other organ when the supply of blood to the myocardium from the coronary artery is not adequate. So the myocardium needs oxygen and the supply is last, so there's going to be mismatch. So again, you're going to see that there one symptom is angina, which is just inadequate blood supply leading to that ischemia causing that pain, versus when the blood supply is really completely blocked to that area, it leads to infarction. So after the physiological factors, we're going to talk about what developmental factors can affect the oxygenation. So infant and toddlers, if we have a premature baby, we're going to have less formed, like well-formed ventilatory system. That is for sure one reason of the infant having premature lungs. Also, the fact that their immunity is less, so they're going to be more at risk for infections. You'll see so many of the upper respiratory tract infection with children. Those children, they're passive, they'll get that secondhand smoke. Also, that is a factor that is non-modifiable. In school-aged children, you'll cover that in pediatric, but they're also at risk for that secondhand smoking, and they're at risk of playing and inhaling chemical household items. Middle-aged adults, young middle-aged adults, they're more at risk of being in unhealthy diet, lack of exercise, stress, illegal substance use, smoking, a big thing. So these are really all modifiable risk factors that we can work on when we want to change the outcomes for for this population, specifically on the cardiac and pulmonary diseases. Older adults, they truly have some changes happening because of the aging process, but such as no calcification of the heart valves, and the vascular changes, the stiffening of the vascular changes, the increased left ventricular wall thickness, the costal cartilage stiffening, the atherosclerosis that comes with aging. But otherwise, also there are some lifestyle factors and elements that we can work on to help in improving that cardiopulmonary function in the older generation. Uh, When we talk about lifestyle factors, some of the risk factors modification that are important, other than smoking cessation, is weight reduction, low cholesterol, low salt diet, real exercise, and management of hypertension, nutrition, adequate nutrition that is rich in essential nutrients will help strengthen the muscles and respiratory function. Um, really, the studies have shown that dietary practice influence cardiovascular disorders. Hydration is important. Exercise will build resistance and endurance. I mean, smoking, even if it's secondhand, it is tied directly to both cardiovascular and lung disorders. Substance abuse is something you have to be able to um, deal with. We have excessive use of alcohol, illicit drugs, direct impact on tissue oxygenation, and especially with the opioid crisis, and now with this post-COVID era, you're going to have a lot of work to do. Excessive use of alcohol and drugs have a definite depressing effect on the respiratory center. Okay, and it is gonna be impacting the rate and depth of respiration and thus impacting oxygenation. Okay, stress is also, as we talked about a couple of times, is a physiologic stress. We're talking about it here. It's gonna impact that sympathetic stimulation, and we're gonna have that constant state of fight or flight, and then uh, it creates the risk for coronary artery disease, hypertension, asthma exacerbation, diabetes, Uh, in addition, we see the environmental factor that affect oxygenation. So we'll see some of places are more prevalent with COPD. Think of how prevalent it is in rural area versus urban areas, some workplaces versus other workplaces, people who work with asbestos, with airborne fibers, with dust. Farm region workers, for example, they're at risk for certain pulmonary diseases because of what they get exposed to with certain fungal inhalation of or some airborne inhalation. Okay. Remember our first talk when we talked about critical thinking and critical thinking attitudes in the first chapters? We talked about this. You really need to know that critical thinking is something you can work on. You need to work on your knowledge, work on your experience, work on your attitude toward critical thinking, work on being aware of the standards that apply in your discipline, work on your attitudes of how much responsibility you have, and that all will sharpen your assessment skills. So clinical judgment, like I told you, is going to be the tool you're going to use at the bedside. And clinical judgment is built on that critical thinking that you acquire now. And when you make decisions regarding your patients based on critical thinking, that's when you are acting and enacting clinical judgment. So all these elements have to be used during assessment. And if you don't use them, you're not going to get to the appropriate nursing diagnosis. Remember, one of the reasons why we'll get to an irrelevant nursing diagnosis is because we did not pick up on those assessments. And why we don't pick up on those assessments? Because we lack the knowledge, because we lack the experience, because we did not read all those standards. So here you have those professional standards that you were required to brush upon and know some of their um, um, standards that they have out there. And one of the requirements was the ticket to class tomorrow is for you to go to the American Lung Association and find what do they have teaching for the patients. As you know, nursing process starts with assessment, and the assessment has to be seen through the patient's eyes, their priorities. What do they expect when they're coming to visit you? What do they bring forward? What is their expectation there regarding their health, regarding their treatment plan? How bothersome are the symptoms are to them, not to you. So you engage in the physical examination of the patient to really see how bad it is, how detrimental it is on the function to that patient. So that's why we say look at it through the patient's eye. So when you're looking at the nursing history, include look for a cough, for shortness of breath, dyspnea, wheezing, pain, environmental exposure. How often do they get respiratory tract infections? Their pulmonary risk factors. What do they bring to the table? What are some of the respiratory problems they had in the past? What medications they're using now? Do they smoke? Do they not smoke? Are they exposed to secondhand smoke then? So, and in box 41.2, it really guides you through some of the questions that you can ask around the cardiopulmonary problem. So look at those. Really, they're very helpful in gauging what questions uh, to ask. For example, if you want to see their diet, ask the patient, describe for me a typical daily diet. And then voila, they're gonna talk to you. You're not gonna have those close-ended questions. And versus when you want to ask them, do they smoke? You want to end a close-ended question. Here, you want to say yes or no. Health risks. Um, talk about family risk factors, what family history they bring to the table. Really, you want to know if they have any cancer, especially lung cancer in the family. Do they have cardiovascular diseases? Were they exposed to TB? Do they have any occupational environmental risk factors? Where did they work in a place where they got exposed to asbestos? And then pain, of course, always with the pain, you need to be thorough, location, duration, radiation, frequency, but definitely any chest pain requires immediate attention. Fatigue, though it's a subjective sensation in the patient, but it is really an indication of cardiopulmonary alteration, and it's really an early sign of worsening of the condition. Dyspnea is that difficulty in breathing is associated mostly with hypoxia. Again, it's a subjective sensation, but also it is, if it's present, you need to investigate. Does it come with activity, with exercise? What makes it worse, And in that department also you need to know about orthopnea. Does the patient have really more struggling with their breaths when they're with their breathing? I mean, when they're laying flat, how many pillows they need to put so they can breathe easier? How do they sit when they sit in the bed or in the chair? How do you see them sitting? Cough is very essential sign to ask for when you in your nursing history, because some bloody sputum can be present with some special conditions such as your tuberculosis. You need to know if the patient is coughing, what type of cough they have, if it's clear, if it's yellow, if it's green. It can tell you stories. That color of the cough will tell you stories. Um, Moving forward, we said we're going to ask the patient about environmental occupational exposures. So we talked about asbestos, but also there are times when the patient is exposed just to some dust, some substances that are only present in certain places. For example, in the construction areas, you have some type of parasitic infections that can be caused just because you're exposed to the demolition of the place. Smoking, we spoke about it, whether it's direct or secondary, it is detrimental both ways. Respiratory infection, how frequent the patient gets them. we all get colds, but it is we don't get bronchitis and pneumonia. So ask those questions. You may have patients that have immunodeficiency that is just that surfaces with that frequent respiratory infections. Allergies, they're big, and really we there is so many allergies that we have around. So ask those questions because um, also when the patient comes to you, they may be exposed to some of the allergies that they have not known about before. For example, if this is their first time getting an antibiotic, they only know that they're allergic to certain food, but now you discover there's allergic to certain drugs as well. When we talk about medication, you need to ask the patient all the medication that they're taking. When was the last time they took it? Don't forget to ask about over-the-counter medications as well as the prescribed medication and herbal medicine, folk medicine, and along that line, you ask about illicit drug and substances. So you need to be all inclusive in when you're asking. Many people who use cocaine, for example, they snort it through the nose. So then you have to be able to collect all the data because otherwise your assessment is incomplete. When you do physical examination, you can review those. I know you just finished your one-on-one and you're more fresh and abreast than me in that department. But tables 4.1 to 4.1.5 go through the detailed physical examination, especially when it comes to the cardiopulmonary assessment findings. And so go ahead and review those. Other than these tables, there is a table specifically about diagnostic studies when it comes to assessment of the cardiopulmonary function, and it's a wide variety of blood studies. And the real test that is done is dependent on what you wanna test. If I'm testing whether the patient has an infection, it makes sense to get the CRP. But if I'm just testing for the functional reserve in the lungs, then it's a different diagnostic test. And then you have in table 41.4 specific cardiac function diagnostic tests, and then you have those ventilation oxygenation diagnostic studies. So these we will focus on, we'll discuss them in detail, read those and know them because you need to be familiar with why you're collecting a sputum. What does a sputum culture and sensitivity show me versus a sputum for acid-fast bacilli? When do we do that one? Versus when do we take a sputum for cytology? Um, this is a quick check for your knowledge. Patient complains of chest pain. When assessing your pain, you decide that its origin is cardiac rather than um, respiratory or GI. What makes you decide that it is cardiac? Between A, B, C, and D, what one is really more indicative of a non-respiratory, non-GI element, and that's A. All the other are indicative of some respiratory variations. Okay, nursing diagnosis. When we talk about nursing diagnosis, we will come up with those nursing diagnoses based on our assessment finding. Please, you put your assessment findings in buckets. You collect all your assessment finding and then try to put them in buckets, aggregate them, collate them together so they give you cues. They will describe the scene for you. You will have a vision in each collection of data around each other, so you need to find if you're talking about activity tolerance, you're asking, putting those assessment that tells you what are some of those elements of the patient when they talk to you that told you that they have activity intolerance. They told you, I can't walk to the bathroom. I can't cook my meals anymore. So these are the things that where you aggregate them and come up with that activity intolerance nursing. Every time you are clustering those specific assessment finding, uh, you're doing that and you're identifying the related etiology for that. Uh, they may be similar. For example, impaired gas exchange and impaired breathing have dyspnea and nasal flaring. But if you look at the assessment finding, you will have more clarification of what the correct diagnosis. For example, a trauma patient who has rib pain and showing increased respiratory rate, they have impaired breathing. That clustering of assessment data will support or negate your nursing diagnosis. In addition, sometimes you cluster the data and it doesn't come to an actual problem. Rather, you see risk for. So you see risk factors aggregation. You think this is a risk nursing diagnosis. And these are also very valid nursing diagnoses. When we plan, this is again a place where we pause and use critical thinking. Same uh, um, depiction comes to you in that figure 41.5, and you're thinking, okay, this is the critical thinking model. I have to bring all the knowledge I have in here, all my experience in here, the standards, the attitudes, and then I go about planning and selecting what nursing interventions I'm going to use that will promote the optimal oxygenation for this specific patient. Remember, when you develop a care plan for each of those nursing diagnoses, your patient has to be with you. The goals have to come from the patient. You need to set realistic expectations. You need to set relevant goals to that patient. And so a patient with impaired oxygenation, we need to have those directed towards meeting those oxygenation needs, but also they should meet the optimum for that patient. We go back to what the normal for that patient is. So when we talk with the patient, collaborate with the patient, we'll have an individualized care plan with patient-centered goals. Okay, so and the goal is more broader. Some of those are depicted in that figure 41.6. If you look at this concept map for a patient that presented with community-acquired pneumonia with a building on a COPD, you see those priority assessments for them, and you see those nursing diagnoses and those interventions for those patients. It is depicting of that some of the goals are applicable for more than one diagnosis. So it is uh, sometimes in the real life you don't worry about it because you're gonna achieve that goal. But in writing a concept map, in your clinical, it can be a little bit tricky. But you can just be very specific, just one goal. Don't go all out on putting multiple things, and that should work for you. For example, patient will achieve bilateral lung expansion. Patient will be able to use the incentive spirometer. You can always put things that you can achieve. But when you setting them, you need to set them with priority based on what is of higher priority. So maintaining a patent airway is higher priority than improving patients' tolerance for exercise, for example. Okay, and what is of immediate need is going to be more important than other priorities. For example, meeting that level of oxygen is more important than activity tolerance for a patient. Always teamwork makes it work. And in the case of respiratory, we said we can't work without those physical therapists. Nutritionists also is of utmost importance because these patients need to be on high value nutritional diet. If respiratory therapists definitely, and then specialty providers for heart failure, chronic lung the conditions, they're going to be working hand in hand with you. Implementation is divided on multiple levels. When we talk about health promotion, primary prevention, secondary prevention, these are some uh, examples you can see in that box 41.6 about patient teaching of prevention of recurrent respiratory infections. That's health promotion, promoting vaccinations for influenza, for pneumococcal vaccine for those who are at risk. A healthy lifestyle, eliminating all those risk factors from dietary habit to lifestyle changes, sedentary lifestyle versus regular exercise, to getting off of those environmental pollutants, secondhand smoking, move from pollutants or use some filters. All these are really effective measures for getting into eliminating some of those healthcare problems that are going to affect the cardiopulmonary system. Um, some of those environmental pollutants, for example, if you know that certain triggers, certain pollens trigger your asthma, you can just keep the windows closed during the season, or use air filters, like we said. Sometimes it just needs some reflection and talking and discussing with your patient. And in the acute care, though, your implementation is going to be more hands-on. A patient's going to come with dyspnea, so you're going to have to deal with oxygen therapy. Sometimes you're working on airway maintenance, the ABCs of life. Sometimes you're working on breathing, and you need to mobilize those secretions so that the patient can have effective breathing. And so you're suctioning the patient, or you're repositioning to mobilize those secretions. Your goal is to promote lung expansion and gas exchange. So your goals are changing here. You're more in the acute phase. Definitely hydration. We talked about how adequate hydration can thin the secretion and makes them more easy to cough and expectorate. Humidification, because especially when we have those dry air, or when we bypass the normal nasal humidification, or when we're delivering high concentration oxygen, we need to be thinking about that. You will see that sometimes they use nebulization, and that's enhances the clearance of the secretions. And sometimes they use the medications also are used with nebulization. Deep breathing and coughing, as well as incentive spirometer use, diaphragmatic breathing. These are all techniques that will allow increase air to the lungs and will allow, the full expansion. And it does help even with dyspnea. Chest physiotherapy, those high frequency chest wall compression, there's always also even beds that do the vibration high frequency chest wall compression. They're mostly used by the respiratory therapist, but sometimes you can also be doing them, especially depending on where do you work. And also postural drainage are used along with those, especially if your patient has a certain amount of secretions that is really hindering and impeding the function. Again, you have a table in 41.6 in textbook, as well as figure 41.7 and box 41.7. They're showing you those chest physiotherapy guidelines. Positive expiratory pressure is an airway clearance technique used with and without auscultation, and it's used more nowadays. You know, you see a couple of different methods. They're used. You'll see also the flutter device. Um, it is one of those PEP devices. If you work in Beaumont, you see that white thing. It is what do they mean about? And this, what that means is what that does is help the air get behind the mucus, and then it is easier to spit it out. In medical terms, it's called expectorate the mucus. Another methods of maintaining that lung expansion is early ambulation. You can't stress that enough. Positioning, put them in different positions. You heard about proning with the COVID and how they put them in a place where it's dependent drainage. Um, but definitely the frequent changes of position, as simple as that, can help reduce that stasis of the pulmonary secretion and improve the lung expansion. Incentive spirometer is meant to encourage voluntary deep breathing. It gives that patient that visual feedback. And it is very have been used for a long time, and it's been proven to promote deep breathing and to promote and prevent lung expansion and prevent atelectasis, mainly in post-op patients. And if nothing works, you're gonna resort to suctioning. Suctioning, you have the oropharyngeal, nasopharyngeal suctioning, you have the tracheal suctioning. Your books talks about them, and then you'll have more of artificial airways, oral airways, endotracheal tubes. Just these are artificial airways to maintain the airway open. You can see those in box for 1.8 in your textbook, as well as in figure 41.14. A patient with a tracheostomy has thick, tenacious secretions. When they say tenacious, that means also they're hard, they're stubborn secretions. To maintain the airway, the most appropriate action for the nurse includes suctioning. Yes, you need to suction that patient. Another thing before tracheosuction is to make sure that their secretions are humidified or lubricate, so that you can suction them. Again, in when we talk about implementation, so we're talking mostly about oxygen use. We're gonna have to discuss the different oxygen delivery modes, from nasal canal to high flow nasal canal to oxygen mask. You're gonna come and you're gonna be able to talk to me about these. When we give oxygen therapy, what are some safety precautions we have to do? And really, you need to come with that knowledge in mind about those different method of oxygen delivery. You have a nice table 41.7 box 41.9 in your textbook that talks about that. Um, when we talk about restorative and continuing care, we're talking about retraining those respiratory muscle to function to their best level. So some of your patients might need to learn the breathing exercise. Some will need to learn the pursed lip breathing, the diaphragmatic breathing, as well as how to handle their home oxygen therapy. We'll discuss also that in a little bit in the classroom. Um, a patient that has thoracotomy, that is the thorax cut, and they put they did a surgery that went inside the thorax, and then they put a chest tube after that surgery. The best method to properly maintain the chest tube would be to um, you don't strip the chest tube, definitely not every hours, and you don't need to double clamp the tube. You can't clamp the tube once to double clamp it. You can't remove the tubing from the drainage device to check for proper suctioning. These are closed systems. So really, the real answer is to place the device below the patient's chest because you need that dependent drainage. And as we started the beginning of the chapter talking about evaluation, assessment, and planning being a intentional thing where we go in with our knowledge, with our experience, with our attitudes, and with all those standards behind. So we know what we will evaluate. We're going to evaluate for signs and symptoms of adequate oxygenation status after all the nursing interventions. And what we're comparing it to is those expected outcomes that we expected after our nursing interventions. And we always see it from the eyes of the patient. Does the patient feel that our interventions were successful? We might think they were successful, but the patient doesn't feel that they have been successful. You know, it is important to ask the patient about their perception of his or her care and compare those actual outcomes to the goals and to the expected outcomes that you have put in that planning phase. Your book talks about safety guidelines. What I want you to highlight here is that you need to really know your vital signs, what's normal, what's abnormal, um, whether the breathing pattern, whether the work of breathing, whether your blood pressure, what's normal in the heart rate and the rhythm, as well as what is normal oxygen delivery. What do we do with a COPD patient? What am I on the look for my patient who has oxygen? Is there any safety concern for me when it comes to that? And see you in class.